Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Mohammad Nawaz, and today the topic of my discussion is urethral injury, and my moderator is Dr. Mazahir. So we'll briefly review different parts of male urethra. Male urethra is divided into interior urethra and posterior urethra. Posterior urethra is further divided into prostatic and membranous urethra. Prostatic urethra is approximately 3 centimeter in length and is the most extensible part of urethra. Membranous urethra is 1.5 into 2 centimeter in length. Interior urethra is further divided into bulbar and penile urethra, which combinedly measure approximately 15 centimeter. Female urethra is divided into proximal and distal part. Urethral trauma can be defined as a breach in the structural integrity of the urethra resulting from excessive trauma. The etiology, epidemiology, and pathophysiology of the urethral injury. First, we will describe interior male urethral injury. The bulbar urethra is the most common site affected in blood trauma. In bulbar urethral injuries, the urethra is compressed against the pubic symphysis. Possible mechanism are straddle injuries or kick to the perineum. Penile fracture can also be complicated by urethral injury in 15% of cases. Penetrating injuries are caused by gunshot wound and insertion of foreign bodies and are usually rare. Iatrogenic injuries is one of the leading cause of urethral trauma. The incidence is 6.7 per 1,000 of patients. These occur by creation of a false passage by inflating the anchoring balloon in the urethra or removal of catheter while anchoring balloon is not fully deflated. Urethral injury can also occur in a procedure like TURP, cystoscopy, or insertion of a penile prosthesis. Posterior male urethral injuries. Blunt posterior urethral injuries are almost exclusively related to pelvic fracture with disruption of the pelvic ring. These are referred to as pelvic fracture urethral injuries and are mainly caused by motor vehicle accidents. These are further divided into partial or complete injuries. Penetrating injuries of the pelvis and perineum, mainly caused by gunshot wounds, can also damage the posterior urethra and are usually associated with other injuries, mainly intra-abdominal. Female urethral injuries. Pelvic fracture are the main cause in female urethral injuries and occur mainly in unstable pelvic fracture. Birth-related urethral injuries are rare and consist of minor periurethral laceration during vaginal deliveries. Urethral injuries can be caused by synthetic suburethral slings. Female urethral injuries are classified into longitudinal or partial, which are the most common type, and transverse or complete injuries. Evaluation of urethral trauma. First of all, examination. On examination, blood at the external urethral meatus is a cardinal sign, but absence of it does not rule out urethral injury. There will be inability of patient to void with a distended bladder is another sign usually associated with complete rupture. The pictorial representation of blood at the urethral meatus following urethral trauma. Hematuria and pain on urination may be present in incomplete rupture. Urinary extravasation and bleeding may result in scrotal, penile, or perineal swelling and ecchymosis. The presentation of these clinical signs may be delayed for more than an hour. Rectal examination should be done to exclude an associated rectal injuries, which may reveal a high-riding prostate. Another sign is difficulty or inability to pass a urethral catheter. Female urethral injury should be suspected from the combination of an unstable pelvic fracture with blood at the vaginal introitus, vaginal laceration, urethroregia, hematuria, labial swelling, urinary retention, or difficulty in passing of Foley's catheter. Vaginal examination is indicated to assess the vaginal laceration. So, investigation, retrograde urethropy, cystourethoscopy, MRI, and ultrasound can all be used in urethral trauma. First of all, retrograde urethropy. Retrograde urethropy is a standard in the early evaluation of a stable patient having urethral injury. It is performed by injecting 20 to 30 ml of contrast material while occluding the meatus and films are taken. Here is a pictorial representation of urethral injury with extravasation of contrast and retrograde filling of the urinary bladder depicting partial urethral injury. Here is another retrograde urethrogram with complete posterior urethral disruption and no filling of the bladder. A combination of retrograde urethrogram and antegrade cystourethroplasty is a standard to evaluate site and extent of urethral stenosis or stricture and to evaluate the competence of bladder neck in delayed cases. Cystourethroplasty. Flexible cystourethroplasty is a valuable alternative to diagnose an acute urethral injury and may distinguish between complete and partial rupture. In female, where the shunt urethra often preclude adequate visualization through a urethroplasty, cystourethroplasty and vaginoscopy are the diagnostic modality of choice. MRI. In complex pelvic fracture urethral injury, MRI provide valuable additional information which can help to determine the most appropriate surgical strategy. This includes a better estimation of length, distraction defect, degree of prostatic displacement, and presence or absence of a false passage. Ultrasound. An ultrasound can be used in acute setting for placement of a suprapubic catheter. Management of anterior urethral injuries. So first of all, anterior urethral contusion. On retrograde urethroplasty, there will be no extravasation of contrast on a urethrogram. Passing a small caliber Foley's catheter for a week will be sufficient in such cases. Partial rupture of anterior urethra. Leak of contrast from urethra with retrograde filling to the urinary bladder. This type of injury is usually managed by suprapubic diversion, followed by a cystogram after 2 weeks. If the urethra has healed and patient can void, suprapubic catheter can be. Complete rupture of anterior urethra. No filling of posterior urethra and no flow of contrast to the urinary bladder. Immediate repair may be carried out in cases of penile fracture or when there is an open wound. Otherwise, suprapubic catheter is placed and delayed repair. Urethral injuries. Insertion of the suprapubic catheter in an unstable patient. A gentle attempt at the urethral catheterization can be carried out by an experienced person. It is highly unlikely that gentle passage of urethral catheter will do any additional damage. Posterior urethral injuries. Early urethroplasty. Urethroplasty can be performed after 2 days and up to 6 weeks. If associated injuries are stabilized, distraction defect is short, perineum is soft, and the patient is able to lie down in lithotomy position. This avoids a long period of suprapubic diversion with its discomfort. Posterior urethral injuries. As a result, complications, stricture, incontinence, and impotence are equivalent to delayed urethroplasty. Laceration, blunt or penetrating at the bladder neck and prostatic urethra will never heal spontaneously and can damage the sphincter mechanism and are reconstructed as soon as possible. Early realignment can be performed in a stable patient. Realignment can be done by an open or endoscopic technique using a flexible or rigid cystoscope. A guide wire is placed inside the bladder. Under direct vision, over this, a catheter is placed if required. 2 cystoscopes can also be used. Posterior urethral injuries. The duration of with early endoscopic realignment, stricture formation is reduced to 44 to 49% compared to 89 to 94% with suprapubic diversion. 50% of strictures after endoscopic realignment can be treated endoscopically. If endoscopic treatment fails, then urethroplasty is performed. Delayed management. After at least 3 months of suprapubic diversion, definitive urethroplasty is carried out via perineal and anastomotic repair or abdominoperineal approach is necessary in cases of associated bladder neck injuries or rectourethral fistula. The overall success rate is 86%. Less than 7% of patients report erectile dysfunction after delayed urethroplasty. The assessment of sexual function and decision on definitive treatment, for example, penile prosthesis, should be undertaken 2 years after trauma because of potential return of potency within that time. Incontinence is usually due to bladder neck incompetence and is in less than 5%. Female urethral injuries. Emergency room management of pelvic fracture urethral injuries is the same as in male patient. Subsequent management however different. Treatment option are early repair, which is less than 7 days. Preferred strategy in hemodynamically stable patient. Delayed repair greater than 7 days. Delayed repair requires complex abdominal or combined abdominal vaginal reconstruction with elevated risk of urinary incontinence and vaginal stenosis. approach, vaginal, abdominal, or combined for early repair depend on location of the injury. Proximal and mid-urethral injury, urethral disruption require immediate exploration and primary repair using retropubic or transvaginal approach with primary suturing of the urethral ends or lacerations. Distal urethral injuries can be left as such if they do not disturb the sphincter mechanism, but an associated vaginal laceration should be repaired. So a diagrammatic representation. Anteurethral injuries, iatrogenic urethral injuries require linear diversion, so urethral or suprapubic. Or blunt injuries, which may be partial or complete, also require linear diversion, periurethral or suprapubic. But penetrating a penile fracture or penetrating injuries, if stable patient, it should be immediately repaired. Posterior urethral injuries. Male posterior urethral injuries, patient is hemodynamically unstable. Suprapubic catheterization is done, or a single attempt at periurethral Foley is done. In stable patient, retrograde urethrogram is performed. In partial injuries, early endoscopic realignment. If failure occurs, suprapubic diversion and delayed repair. In complete injuries, if patient is stable, if patient is having associated bladder neck injuries or prostatic injuries, it should be early repaired. And if not, associated injuries are treated first and delayed urethroplasty is performed.